Thank you very much, Valentina, for the kind introduction. So I'll be talking today for a topic that maybe is a little bit different from what we heard and also what we have heard me speaking about over the last several months. So I'll be talking about musculoskeletal MRI. I had the privilege to work on this topic for several years, actually going back almost 20 years ago. So if we actually look at the type of MRI examinations that have been performed and how they are grouped in terms of anatomical locations, this is data from two different studies. In the middle, you have data from Canada here, and in the right, data from France. And as you already suspect, brain is the most frequently scanned anatomical location, followed by the musculoskeletal parts, which you see on the middle, it's defined as musculoskeletal, on the right as jointed bone, and by the spine, and this can actually go in different orders, musculoskeletal and spine. A spine is a big focus also for the musculoskeletal side, not only for the neuroscience, they tend to be grouped together. And the third or fourth area, if you want, is the abdomen and the pelvis. So for those of you who have been to the lecture I gave at EPFL a few months ago, this is a slide that you have seen before, and there I focused a lot on the work that I have been doing and also the previous group that we are having at the Technical University of Munich on abdominal and pelvis MRI. And today I would like to focus really on what happens when we look at the musculoskeletal system, and this involves the extremities and also the spine. And I do promise you this is the only slide that's the same with the inaugural lecture, because I got this question before. So this is a topic that's a little bit different from all the topics that are currently running in the center, and of course there are very strong musculoskeletal MRI researchers, also musculoskeletal radiologists in the two university hospitals, and of course a lot of people that I have not met since a few months that I joined that also have an interest in musculoskeletal health. But just a quick introduction on what happens when you actually have a musculoskeletal MRI exam. The protocol is primarily defined by multiplanar 2D proton density and intermediate weighted fat suppressed scans. This includes also, in addition, many times non-fat suppressed T1 weighted scans to look especially on bone. And if you have an oncological question, many times you give contrast agent to the patient just to know really what happens if there is a suspicion of malignancy. So this is the type of images you get. These are images actually post-operative of the knee of two different patients, and then they have two different outcomes. So these actually are patients that have already received some type of cartilage repair. And you see that here the cartilage repair is integrating quite well, although the top is not integrating very well. This is an intermediate weighted sequence. The echo time is usually 50 to 60 milliseconds, so it's not heavily weighted, it's not really proton density. On the other hand, you have to do that in multiple planes, and you say this is like a very interesting topic where 3D imaging in musculoskeletal MRI has not really made it full all the way, although it's being increasingly adopted in different sites. You have to scan anatomies that are varying very rapidly in 3 dimensions, and this is here an example here of the hip. So this is really looking at the articular the cartilage really surrounding the hip. And this, of course, a structure that you can imagine the hip, the femur is really like a sphere, and then you have really a huge problems with partial voluming, and many times you perform actually the imaging at different planes. Musculoskeletal MRI has changed over the recent years, and since I have started seeing it like really actively being used when I was still at UCSF 15 years ago, it's the field that I've seen they strongly benefit from the latest generation of acceleration techniques. I was very fortunate in Munich to experience that through the collaboration that we had with the vendor at that time that we had. And just really to show you really how modern musculoskeletal MR takes place, it's very important when you have these two-dimensional protocols to really accelerate them, because you want to have a higher throughput and, of course, potentially increase the type of information that you want to get out of your protocol. So here is like, the paper by Mickey Lustig and compressed sensing was in the early 2010s. And then, we have here the methodology of compressed sensing reaching really the vento. Here is the images from the ankle using only traditional power imaging and introducing compressed sensing, so random undersampling, and on top of that, an LOL regularized reconstruction. And you see that the benefit you get from a standard reduction of R equal to 2, you can go up to R equal to 2.5. On the other hand, over the recent years, and this has happened quite more rapidly, as you see, these are the papers that we had in Munich when we first got this software, so I basically helped the radiologists do this evaluation. We have here a deep lane-based reconstruction using more advanced regularizer, using deep learning and going from an R equal to 2.5 to 5.1. So here, from compression sensing, an impact by reducing the total scan time of the order of 20%, and deep learning coming in for this type of two-dimensional imaging, where you can, of course, with compression sensing, not increase the acceleration to a quite substantial reduction here by a factor of 50%. So this is the type of images we get. So someone could say, okay, this is actually boring. Why should I care about that as a researcher? You know, this is intermediate weight sequence. I mean, most of my previous research group in Munich had went to MRI in these anatomies because this is the most frequent type of region to enter the MRI scan to have an orthopedic problem, because most of the young people do sports. But why to do really research in this area? Everything is done. Well, it turns out that there are a lot of very important questions that are still pending. So there are structures like the bone, for instance, like here, the cortical bone, the thin layer structure of bone, or the temporalized bone that you cannot correctly characterize with MRI, and of course X-ray is doing much better. On the other hand, you have this here, this cartilage repair site that I showed you before. Okay, you see a little bit qualitatively already with the grading that, you know, something is doing better on the bottom and on the top, but what is really happening to the biochemical composition of the tissue? So quantification is important. It's a topic actually where a lot of research has been taking place, also in cartilage. I will not be talking a lot about cartilage, but try to explain you some other examples of quantitative MRI protocols in MSK tissues. This is actually exactly really translating what I just said in terms of MR sequences or MR acquisitions. On the left here, you have the trabecular bone assessment being performed with a high resolution, balanced, steady state, free precession acquisition. And you can see really like, you know, that bone grows much better on the bottom and on the top. And then you can have T2 relaxation time, showing really the fact that, you know, here the T2 of the cartilage, of the graft that you have inside the cartilage is actually much closer to the T2 that you have on the top, where, you know, it's still very thin and very high T2 values. So for the rest of the presentation today, I will try to tell you our journey that we had in my previous institution and what we are starting now here at EPFL, at the CIBM, to develop novel ways to generate MRI custom for bone, so generating contrast for tissues that we cannot easily traditionally get a signal from. And I will show you an example of a direct approach to do that and an indirect approach. And I'll be talking on the right a little bit more about quantitative MRI of musculoskeletal tissues, especially in the context of skeletal muscle and peripheral nerves. If we actually think about MR-based bone assessment, because again, this is a topic that is not super familiar, the topic, I just want to get a very basic background of why you would like to do that. On the one hand, is systematic metabolic bone disease like osteoporosis. There, X-ray techniques can be used to measure the bone mineral density, and having a threshold or a T-score, as it's called, for bone mineral density, depending on the age of the subject, we can get an idea whether this patient is at risk for fracture, and then actually you can give a medication to these patients to get to protect them. But only 40%, especially in the spine, of non-vertebral fractures occur in women with osteoporotic BMD. So sensitivity is really a question in the context of osteoporosis. On the other hand, we have the general topic of MSK degeneration or trauma, where X-ray and CT techniques can be used, but of course, sometimes, especially when it's CT, we don't want to use it. And of course, at the same time, we need to perform an MRI for having soft tissue contrast derived. So can we have the MR-based bone assessment on one-stop shop examination, where we have also the soft tissue information from the MR? So you can do that by looking at the bone and directly measure the signal of it. Well, the issue is that the bone has a T2 star of below 0.2 milliseconds at 3 Tesla. So conventional MRI has a minimum echo time of around 1 millisecond, and basically bone looks just dark in a traditional MRI sequence. A traditional MRI sequence has the part about signal generation here, has a part where we evolve the signal. Well, we have to do it in order to perform these prephasers and moving around in the spatial encoding dimension in the space, in the K space, and we finally need to perform a signal detection. Well, there is a family of technique called ultra-short echo time techniques, where you're able to actually measure the signal much earlier, so not that late as the one shown here. To do that, you need to change a few things. So first of all, you need to remove the evolution part and then acquire the data as fast as possible, so acquire the center of K space immediately after excitation. And now, in addition of that, you need to do a non-selective excitation pulse, and this has also some implications on how you have RF excitation and T2 star decay effects happening at the same time. And finally, you have the situation that you have to go very fast on the readout, as fast as possible, minimize the echo time, and you sample during the ramp of the gradient here, trapezoidal gradient that you have as a readout. So in that way, when we are sampling over this ramp, we need to have a precise knowledge of the actual gradient waveform. The problem is that the modern MRI systems are not always giving us the gradient waveforms that we really want. This is what we're designing as a pulse sequence developer, or we know what is translated into the spectrometer in the general sense as we are describing a protocol. This information has to pass through the gradient amplifiers, and this introduces system delays. Finally, we have eddy currents that are being introduced because exactly we are passing time-varying magnetic fields through our gradient coil and all the conductive parts of the magnet. And finally, we have vibrations kicking in. The way to describe all this is going away from this gradient input intended. This is what we would like in our pulse sequence diagram to a real one, what is really like, played out, which you see is delayed and also has this rounded type of corners. If we assume that we have a linear time invariant system, we can think of it of describing the MRI system as a transform function. And here, this type of transform function is actually the function that we will have in the description of basically the system, the gradient behavior as a function of frequency. And if we take the Fourier transform of this type of function, we'll get the gradient impulse response function convoluted with the gradient waveform. We can get finally the output, the real output gradient waveform. And this is how it will look in the case of two echoes here for the UT. You start seeing that things are looking quite differently, and this is actually here on black. You see the difference. Sorry, on blue you see the difference, like in terms of gradient errors that you have. The way to measure this type of system function, the most formal way, and also take into account all the imperfections of the system, would be to use a field camera approach, and this is a separate piece of instrumentation that you can put inside your scanner and measure that very reliably. As a separate type of measurement or a separate experiment. We are very, very fortunate here at CIBM, and specifically for the FCBG scanner at the 7T scanner in Geneva, to have such a new piece of instrumentation. It arrived since a few months, and I just want, since a few weeks, I would say. And I would like to point to you to Li Jing if you would be interested to learn more about it. And this is definitely a very exciting opportunity, especially for this system, because you can actually have any type of case-based trajectories also being connected for non-Cartesian acquisitions, for diffusion acquisitions, and so on. However, when I was doing this type of work, or doing it in our previous institutions, we didn't have a way to such unique instrumentations. So in this way, we had a similar approach to measure the transfer function using standard hardware of the scanner and a phantom. And the idea here is actually to relate the phase of the signal with gradient strength, because phase is proportional to the integral of the gradient in this context. And then we actually do that at different locations, different slices. We excite the thin slice to measure the gradient at specific locations. And we actually do use a gradient waveform that contains a high number of different frequencies. And we are swept to the different frequencies with the final goal to measure this transfer function that I showed you before. Okay, enough about how all this is done. Let's just look at some images really here of ultra-short echo time, looking at the spine. Here are UT images using this nominal correction. This is a standard delay, just looking for one delay. On the middle, you have here a gift-correct acquisition that really reliably measures the gradient waveforms. And this type of images, you see that the bone actually looks relatively dark because it has a lower proton density, but still is an ultra-short echo time acquisition. What you do many times is you invert the contrast, so you go to the images on the bottom, and then there you can see that we have here a much better delineation of the cortical structures of the bone in the context of the gift-correct acquisitions, a much better comparison to CT. This is an acquisition with a radial stack of star acquisition with a total scan time of the order of 7 minutes. Well, just looking at some focus images here, these are patients that have had vertebral fractures. So this is a type of site where you have a fracture here. And this type of fracture, you see that when you look at the bony structure here being deformed, exactly because you had acute trauma in these patients, you can see that we have, using the exact waveform, the exact knowledge of the gradient waveform, we can have a much better agreement between the gift-corrected or the gradient modulation transfer-corrected reconstruction compared to the CT prior. You don't need to do that only for spine imaging. You can also do it for looking at the cortical bone in the knee. Here, the cortical bone is very thin layer. If you just use the nominal corrected, the standard delay only, you start seeing the nominal, the cortical bone layer not being reliably depicted. And then, when we start using exactly the waveforms that they are played out on the system using the modulation transfer function, we can more reliably find really the cortical bone structure. Another area where this could be of interest is not only for looking at bone, but for calcified tissues. The deep articular cartilage is one type of this type of calcified tissues, and this is also very linked to, closely linked to the occurrence of osteoarthritis. And here we have a traditional Cartesian acquisition looking at, the patellar cartilage, and, at this T of almost 600 microseconds. Here we can go a little bit longer on echo time. We can see that once we have this type of appropriate correction for the gradients, we can nicely see the cortical bone and also this very thin layer of a white signal. It's a T1 weighted acquisition, so we need to induce a little bit of T1 weighting to really the deep articular cartilage layer. The problem with the UTE acquisition, if you want, is that you need to invest additional scan time. And this might not be always so beneficial because you need to consider what other type of scans you have inside your imaging protocol. So what we did next was to look at if we can actually get more information from the UTE scan in addition to the bone information in order to be able to replace the information we get from another sequence. And this was specifically relevant in the context of acute spine trauma. So in acute fracture, SCT is usually the modality of choice to assess bony textures, and MR can be used depending on the site. There are different opinions on that also when we talk with trauma physicians or musculoskeletal radiologists. MR could be used to assess edema. Well, in MR, what you do to assess edema, it's a T2 weighted sequence, and when you do musculoskeletal MR in many sites, you don't even use Dixon, but use this short-time inversion recovery sequence. So using inversion recovery to suppress the fat and get really the edema that happens in the bone marrow. And then you have, on the other hand, the UTE scan. So can we actually get the bone information from the UTE, and then the UTE scan really also give us information about the water and fat, the presence that we have, more edema in this specific body compared to that body. So ideally, you would like to put the two information together, the deformation of the cortical bone structure or the periphery of the vertebral body here, the geometry, and the information from the edema at the same time. Well, we have to look a little bit more carefully on what we are measuring. So it's a gradient echo acquisition. We are measuring the signal as a function of a given time. We have a water part and a fat part, and some type of phase here, and a chemical shift introduced by the presence of fat. So we have the water, the fat signal. The C of T for a given echo time, if we know the fat spectrum, and this is easy to calibrate, is actually known. And we have, in addition, an unwanted common phase. This phase that carries on B0 inhomogeneitis, eddy current, signal delays, and B1 transmitter receive phase. So we have one signal, so this one complex MR number, and three unknowns: water, the fat, and this background phase. So of course we have a problem that has multiple solutions. How to get rid of it? How to get rid of the phase and move on with calculating the water and fat components? Well, if we actually look at the magnitude of this UTE signal, that's the type of image we have at 0.14 milliseconds or 140 microseconds. And if we look at the phase, we will see that the sagittal and the coronal view and the transverse view looks like there is some type of information that's being encoded by chemical shift, but there's also this background phase that we don't like to have, and of course this will not be that we need to get rid of. And if we actually look more closely at the background phase, we will see that we start having this slowly varying phase background that we will need eventually to take care of. And the way to do that is by formulating a smoothness constraint, nonlinear inverse water-fat problem. So we have a data consistency term here, and also we apply a constraint that this phi, the background phase I mentioned before, especially smooth in the image domain that we have, usually the 3D domain that we scan. If we do that, we're able to estimate that type of phase, and after we remove that type of background phase, we're able to have here an image that looks quite nice, because I have here all the phase information being encoded. This is a disc, this is a bone, a vertebral body, so I can really see the water-fat contrast very nicely. And if I do the subsequent water-fat separation, the cool thing is I have water-fat images, and for instance, for this case, it's a case of a patient that has actually in this vertebral body here a fracture. I can very nicely see the edema. So there's more water on this vertebral body and less fat for this vertebral body. So how can I put all this together? I take the UT images, and this is here an example of volunteers inverting the magnitude information. I look at the phase information. I remove the bulk phase or the phase of the background I mentioned before, the phi. I have information here on the phase that is only relates to the chemical shift. I use that type of information to separate water and fat, and I get from one scan an information that is related to bone and water-fat images that are very close to the clinical relevant clinical correlates I would have if I would use just a standard clinical protocol. Well, this is not only working just in volunteers. This is a study that we did in Munich in 30 patients with acute spine fracture. Again, on the right is a CT, a separate scan, and the MR is another scan, which again, for these specific cases, let's say we look at the case here, we have, a type of fracture on this level and edema from that side. We can look at the UTE signal also here, like really showing very nicely the different parts of the bony structure being affected. Even here, these are some osteophytes, like these are bony structures that are really bone was not supposed to be there. And if we eventually look at the water and fat image, we can very nicely again see the spots of the edema and the actual fracture site. This can be also done not only with the technique that I showed you before in the spine, can be also done in the context of extremities. There you need to go ideally to alternative trajectories and isotropic resolution. Here is the same type of concept showing you before, looking from the MR, the CT-like image, the water, the fat image, and very excitingly, if you see like here on the MIP, throwing through the images, you see that here we have also the ability to look at on the water image, we can see very nicely the vessels that running through the bone, which in traditional echo times would not be able to see. So this concludes what I wanted to tell you about the direct approach to measure bone. There's also ways to look at an indirect approach. And an indirect approach would mean that actually we are getting no signal from the bone, but we still use the physics of the MR image formation to actually get information that is useful. And the way to that is using the so-called technique quantitative susceptibility mapping. And the idea is very simple. I have here the example of, in the context of osteoporosis or bone health, you go from normal bone to osteoporotic bone. Bone tends to be more diamagnetic, so it tends to have more negative chi. So you go to osteoporotic, you have less bone, chi goes up. The magnetic susceptibility goes up. The physical principle of how chi distorts the local magnetic field is basically here you have the local field map measure and you have a convolution between the susceptibility map and the dipole kernel. This dipole kernel is known from magnetostatics, just from basic physics know how, for a given sphere, how much, if the susceptibility of the sphere is different than the surrounding, how much it will distort the surrounding field. Well, the easy way to solve this type of problem is, going from the convolution, go to the Fourier space. So from the image space here to the Fourier conjugate space, and then you have here, you replace the convolution by a multiplication. The problem is the type of dipole kernel has zeros at specific locations, and this makes the problem ill-posed. So the QSM in the body is in general challenged by the traditional challenges of the QSM, and this is the ill-posedness, but also challenged by the presence of fat, the residual effect of background fields and boxes with low SNR. I don't have time to describe all that, but we developed a full-blown technique which we used in different body locations, although it started in the spine primarily for QSM. And this is an example here in a highly relevant cohort of patients with osteoblastic and osteolytic lesions. So osteoblastic lesions would suggest primarily some highly suspicion for malignancy. Osteolytic would be more benign. And this is here an example of in a study with n equal 10 patients. Here is the type of gradient echo acquisition that we use, the different type of parameters. And I want to point you out here on this water fat TFI map is a susceptibility map, and is able really to show the very negative values of chi. This is unreasonably low, which relates essentially to the presence of the osteoblastic changes, apologies, inside the vertebral locations, and also the changes we have for localized areas here. So yeah, QSM cannot be used only in the brain, but in many applications, like for instance, search of calcified tissues is very useful also in other body parts, and of course, musculoskeletal imaging is one area of it. I don't have a lot of time, but I would like to just really briefly focus a little bit on developing techniques for quantitative MRI of MSK tissues. I would like to talk about two specific examples because this link also to some of the current work that we are trying, we have kick-started here in the Lemanic region. The first one is neuromuscular diseases. So neuromuscular diseases are in general of genetic origin. They are rare disorders. And however, nowadays there are more and more pharmaceutical interventions, and there are more and more drugs being developed. The situation there is that you have a lot of functional tests being developed, and you would like to have non-invasive outcome measures to replace biopsy. You can measure the fat infiltration of skeletal muscle. This is known techniques like fat quantification techniques. The challenge then is that already when the muscle is weighted, doesn't make a difference. Or what you like to do is you like to look at disease activity. And this is an example here of a T2-weighted stir, so sometime inversion recovery, so stir for fat suppression. You see a bright spot here, but it's, is fuzzy. You know, what is really happening here? We cannot be 100% sure. And of course, when you develop a drug, you want to know how well this patient is doing when you longitudinally follow it. Of course, it's a very good way to do that using quantitative T2 mapping, going away from the T2 weighted sequence to T2. There, in the work that we did in Munich, we used the T2 prepare 3D turbospineko, and using this technique, we addressed transmit B1 effects, and also we saw that this technique can actually overcome some of the issues that we have for fat suppression compared to the multi-echo spineko. So this type of technique, the T2 prepare 3D TSC, was also used in the context of peripheral nerves. And peripheral nerves is actually a topic that is attracting more and more attention, also to being performed with MR. This is highly relevant in the context of peripheral neuropathies. There, we would like to know the nerve lesions, where they are, how they can be treated. There are solutions so far, electrophysiology, ultrasound, and high-resolution 2D imaging. But this is the 2D imaging that you can have, and it doesn't project well here somehow. But this is the type of small peripheral nerves here in the arm that you would like ideally to see. And you would like to have ways to go away from this T2 weighted imaging and characterize the lesions. This type of method that I showed you before for the muscle can be applied also in the nerves. And this was a study we performed in Munich, showing in case of patients with entrapment of the nerve in the spine that we're able to see that we have basically on the affected side higher T2 values than the contralateral side. But if we actually take a look and look at the peripheral nerve image, this image should be nice and now. We look at the, here, this sciatic nerve location, and we focus on the T2 map, and we see at the T2 map here, or in general in the delineation of the anatomy, we see that we don't really able to look at the organization of the peripheral nerve. The peripheral nerve should look like that. Should have a structure, you know, with fascicles, and then, of course, has way more details than the typical MRI voxel. And this is really a very good example to play around at exploiting the higher sensitivity of the 7 Tesla scanner. This is work by Emily Slide, and Emily has also a nice poster on this today, later this afternoon, and this is all data performed at the FCPG scanner in Geneva. So you have here the T2 map, and you can actually, when you use this type of multi-echo spineko, you need to use the extended phase grabs to get rid of problems. And this, you see here a little bit higher T2 values that you're able to flatten out when you use the EPG compared to the conventional exponential model. This is a type of transmit B1 map you have at 7 Tesla, which of course is not, it's more challenging than 3T. And then we have here the M0 maps from the mono-exponential model, really being able to see very nicely the different fascicles that I showed you before here on the M0 map, and also comparable information compared to a DES, which is an anatomical reference sequence. And the cool thing is that we can do that combine also with the T2 map, and we can combine the information from the T2 map and the type of photon density information we get, or the scaling factor from the T2 mapping, and being able to find for individual fascicles the T2 information on a single scan. Of course, the challenge when looking at this type of acquisitions at the 7 Tesla is that we are very limited, the human 7 Tesla, the FCPG scanner, we are very limited in terms of RF coils. And this, I think, where, because the current coil that we have primarily is an E-coil and has a limited coverage and also a limited diameter. What you could do, you could think of ways like the work that Daniel is doing, Daniel Vents from the CIBM, to looking at twisted pair coils for legs of different size and integrating dipole antennas and dielectric isolation to finally boost the signal-to-noise ratio. So this brings me to the very end of what I wanted to tell you today. I gave you a quick overview of different novel ways to generate contrast in musculoskeletal MRI, and show you an examples of bias-free and high-resolution T2 mapping as one example of quantitative imaging. There's definitely more to come for us in this arena in the context as the group is growing. We have already a PhD student who started on UT imaging, and of course we're still exploiting the activity at the 7T scanner. I don't have a proper acknowledgement site. Everything for me is still under construction, but I would like to take this opportunity and thank everyone from the CIBM for the work outcome over the last 8 months. Getting to know every one of you has been really one of the most exciting parts of really moving to Switzerland, and I'm looking forward to following this journey with all of you. Thank you.